And when I was asked to talk on scleroderma lung disease, you know, it was quite evident this topic I wanted to talk about is understanding your pulmonary symptoms. And very shortly you will know why I find that very important, especially with my scleroderma patients. You know, most of my scleroderma patients that I do see, they are very well read compared to other interstitial lung diseases. And I think that's important because it's a disease that some providers are still getting to know of. And I think when our patients challenges us, it's a good thing. I also find that most of my scleroderma patients are up to date with literature. So I didn't want to talk about those trials that are going to be out there, but I wanted to focus on something that can change the lives of my scleroderma patients. And so what I was going to talk about today, I was going to focus on understanding that symptom of shortness of breath, which a lot of our patients with scleroderma might have, or even chest pains or symptoms along those lines, and try to see whether we should be chalking it up all to scleroderma or something else. Okay, so the overview of my talk today, we are going to talk about evaluating these pulmonary symptoms. We're going to talk about risk stratification and screening of the patients from the pulmonary perspective when it comes to scleroderma, targeting symptom control, and also monitoring for these new medications that we have out there for toxicity. You know, one of the things that we say in academic medicine is new medications don't have side effects, right? Once they've been out there for some time, that's when we start noticing these side effects. So one of the things that, you know, as we were sharing these stories today, you can see there were a lot of commonalities, but also there were differences. And I think to be able to identify those differences, to individualize that pathophysiology is very important. So one of the things I talk about when I see a scleroderma patient in the office, the first thing I will try to figure out is what is the phenotype of this person, this scleroderma, because no two patients are the same. They may have similar symptoms, but they also have different symptoms. Just like we talked about, some people might respond to Plaquenil, some people may respond to prednisone. Why are they responding differently? What's different? And what were the symptoms that they're trying to control? Maybe it is pain. For some patients, it may be shortness of breath. For some people, it's I just feel better, you know. But why are they behaving this way? So it's very important to understand that different phenotypes. And as we all know, different organ systems can be involved. We have, do you have a PowerPoint, Fee? Fee, do you have a PowerPoint?
I'm sorry.
I'm sorry, a laser point? Laser? Yeah.
Sorry.
Okay. So, you know, the respiratory symptoms can be affected, and we're going to talk about that in detail, so I'm not going to dwell on that. It can affect the renal system. You know, patients they'll have, you know, serious renal crisis. We can have a gastrointestinal symptom that gets affected. We have aspiration pneumonias, we have reflexes, aspiration bronchitis. Skin, you know, the diffuse disease, you can have skin involvement. The limited disease also, you can have skin involvement. Cardiovascular disease cardiovascular symptom can be seen, you know, with pulmonary hypertension and Raynaud's phenomena and with digital ulcers. We also have the musculoskeletal symptom involvement. But what's interesting is this: if I were to just take those four quadrants there, shortness of breath, cough, fatigue, and chest pain, if you look at it, you know, they look like pulmonary symptoms, right? But if you think about it, and it's so easy when it comes, you know, to certain diseases to chalk it up to something when we see something wrong. If we find a chest x-ray looks wrong, let's chalk it up to that, you know. But is that the driver of the symptoms? Are we missing something else? You know, is that the best our patients could be? Our patients could have pulmonary hypertension. We treat the pulmonary hypertension, the patient still has residual shortness of breath. Is that where the patient is going to be the rest of their life? Or is there something else driving the shortness of breath, right? Or a chest pain for that matter. So if you think about a simple symptom of shortness of breath, it could come from a cardiomyopathy, it could come from pulmonary hypertension, or a simple renal crisis that is causing more fluid in the lungs, and that is making a shorter breath. Or it could be the muscles. Our muscles are weak that we feel more shorter breath. Thank you. Or our muscles are weak that we are shorter breath. Or even the medication, some of the medications we give our patients, right? That can cause us to be shorter breath, make a shorter breath. The other thing to think about is that symptom of cough. You know, when you think about cough, you think pulmonary, pulmonary, pulmonary. Well, not exactly. A lot of my patients that I see with cough could come from other causes, maybe a GI cause, maybe from a cardiac cause, maybe a renal cause. But it could come from scleroderma, especially when you find all this pulmonary fibrosis. But there's so many other pulmonary diseases that gives us a cough. So the question is that cough really coming from a scleroderma-derived complication, or is it from a non-scleroderma-derived pulmonary complication? Now that is what we need to really sit down and ponder and think about it. Chest pain, it could come from, again, a cardiac cause, a GI cause, even pleurisy could come from. Some of our scleroderma patients develop this annoying chest pain. It's nothing they can put their finger on, but it's there. It's annoying. It comes and goes. They sometimes have to take the medications like Plaquenil. Plaquenil helps for those kinds of pain, sometimes with the serositis kind of pain. But then the question we ask ourselves here is, at this point is, when we have all these symptoms and we have pulmonary diseases that commonly happen, let's give an example. I have a smoker, for example, a patient who smokes, who has COPD. But now what happens over the course of the years, they has developed the diagnosis of scleroderma. And now the patient gets more short of breath. And now all of a sudden we do a CAT scan and we find all those fibrosis and we're chalking up that to pulmonary fibrosis. I see a lot of that happening. So that is why I wanted to spend some time understanding these symptoms. And I think one of the things I also see is when our scleroderma patient comes in, they are so worried about this diagnosis. They also tend to be a little bit focused on the diagnosis of scleroderma. But I want them also to start thinking about it and telling those symptoms that may point out that it is not necessarily my scleroderma to the provider, but something else going on. I want you to figure that something else. What else is going on? Okay. So you can see there's a lot of pre-existing conditions in our scleroderma patients, COPD. They might have had lung cancer, asthma, chronic bronchitis, or they could have an interstitial lung disease to begin with from something else, and now scleroderma has come into the picture. What was interesting is what we were just sharing now about these connective tissue diseases, some of which we have a diagnosis, some of which we don't have a diagnosis, some of which we talk about, they have common symptoms, but we wish we had that terminology. When I used to tell my fellows, I used to tell them this thing. When we have these connective tissue disease, we like to have those patterns of disease where we can put a patient into lupus, rheumatoid arthritis, mixed connective tissue disease. But we have those patients who don't really declare themselves. It's like sitting on a stoop and seeing someone walk from far away. You can see that person in the shadow, but you don't know it's a friend or not. Is it a male or a female? Sometimes that person comes out of the shadow and you can say, yes, I see this pattern. I see this pattern, I can put them into this group of lupus, so I can prognosticate these patients. But very often that person just stays in the shadow, right? Then that is where the finesse of medicine kicks in. That's when we sit down and ask ourselves, what exactly is going on in this patient? Do I really have to give the name to that disease? So sometimes I tell my patients, well, I don't have to give you a verbiage of the disease. I may not be able to prognosticate you well, but I'm going to closely follow you and try to identify, are you going to declare yourself at time, or you may not declare yourself at time, you may just stay right there. So that's the thing with this connective tissue disease. And we all know there's more to it than meets the eye. We have given these names, but a few years from now, we'll be able to have those biomarkers that can keep us in can sway us in one direction or the other. So when I see a patient in the office, this is the due process that I take to my patients. So let me give you a prototypical patient. Let's, for example, I have a 45-year-old, this is a hypothetical patient, 45-year-old patient who is an artist and spray paints. And she noticed that around 6 to 7 months ago, let's go back, 2 years ago, she noticed that when she was trying to spray the spray paint, she was having a lot of pain. Her fingers were swollen. And she went to a primary care doctor who said, maybe this is rheumatoid arthritis. Let me send you to a rheumatologist. She gets diagnosed with scleroderma. And then they've been keeping a close eye on her. They've got all the biomarkers they need. And they're closely following that patient. However, 6 months ago, this patient noticed that she started getting more short of breath. She also had not just shortness of breath, she's also having a cough. Goes back and sees the provider, and the provider says, why don't we get a CAT scan and see what's going on? And they do a CAT scan, and they get the CAT scan and see that she does have some interstitial changes on the CAT scan, right? So let's say the patient gets sent to a pulmonologist. Now we are sitting down here, we're trying to figure out what's going on with this patient, right? The first thing to do, and I'll walk you through all of these steps, is to get down to the basic. We have to take the diagnosis. Usually I tell my patients, I know you have a diagnosis of scleroderma, but what I'm going to do is I'm going to take the diagnosis of scleroderma and put it aside for now. Let's talk about everything else. I want to know her history, occupation, whether she had under baseline lung disease. So I'll walk you through the process. So the first thing is to get down to the basics. After I get down to basics, the next thing I'm going to ask myself is I'm going to risk stratify the patient. What are the chances, what is the pre-test probability that this person is going to develop pulmonary consequences of that scleroderma? I'm going to add that, I'm going to layer that on to the basic, once I have the basic. Then I'm going to ask myself the question, so I know this is what she has. She probably had a pre-existing lung condition. This is her risk stratification. Now, how much of those symptoms, that simple shortness of breath that I'm seeing, is actually coming from the interstitial lung disease, what I'm seeing on the CAT scan? And how much of it is coming because of something else? Maybe an asthma. This is where we live. Lancaster, Pennsylvania is the allergy belt in the country, right? Is the asthma belt in the country. Could it be that? And then what I'm going to do after that, once I come up with a hypothesis, so my hypothesis is this is causing that, so if I treat this and that gets better, it's no more a hypothesis, it becomes a fact, right? Because the patient still has that interstitial lung disease. So that's the way I usually walk my patients through the process. So to understand your pulmonary symptoms, the best way to look at it is this way. Think of the lung. Think of two parts. Think of the lung here with the associated airways. These airways, as you can see, this is the trachea. This divides into the left and right bronchus. And these tubes keep on dividing till it gets into very, very small tubes. And those tubes ends up in the alveoli, the little rounded sacs that you see there. And that alveoli is covered with a bunch of blood vessels there, right? And if I were to take each and every of these alveoli and put them side by side, the surface area is 84 square meters. That is the size of a tennis court that is wrapped around our chest. We can never overwhelm that. A lot of lung disease has to happen before we start noticing we're getting short of breath, right? And that becomes important because just think about this. When we have patients with lung cancer, we can take a whole lung out. And the patient may not even miss that, right? But if I do a CAT scan and I start seeing these changes and I attribute everything to that, I'm missing the boat, right? The other thing to think about is the lung is now, if you take that whole lung and put it into that cavity there, that's your chest cavity. And your chest cavity consists of the ribs, the muscles, and that curved structure down there is the diaphragm. 40% of the breath that we take comes from the diaphragm. And then we have got the skin that wraps around it, right? Okay, so when you're looking at the pulmonary manifestations of scleroderma, it can affect each and every structure. It can affect the airways we talked about. It can affect the lungs itself. So the airways we talked led to the lungs, and in the lungs we've got these blood vessels that wraps around the alveoli, right? So it can affect, the shortness of breath can come from the airway, can come from the lung parenchyma, it can come from the blood vessels, right? It can also come from the surface of the lining of the lung, that's called the pleura. Also, symptoms can come from cancer. We do know that interstitial lung disease is associated with increased incidence of lung cancer, independent of whether the person smoked or not. Then coming out of that, talking about the chest wall that gets wrapped here, if the skin around the chest is thick, we might have the perception of shortness of breath. It may even cause our carbon dioxide to go up and give us that fatigue. The muscles can sometimes be affected. The space there can be affected. Sometimes we have a pleural effusion. But one of the things I always try to point out is if you do find pleural effusion in a patient who's got scleroderma, think of other causes. Not as a direct consequence of the scleroderma, but maybe the scleroderma is causing cardiomyopathy and that is causing a pleural effusion. But directly as a consequence of that, probably not, less than 10%. So we do know now data is coming out about sleep apnea. Sleep apnea is at a higher, we have a higher incidence of sleep apnea in our scleroderma patients, or interstitial lung patients for that matter. And sometimes our fatigue that we have, the aches and pains that we have, sometimes can come from that, and that sometimes goes undiagnosed. So you can see it can come from any of this. Now I'm going to spend some time on this slide because I think this is a very important slide. So let's go back and go to that prototypical patient, right? So the patient has told us a couple of things. She said, I've been doing well. They have been keeping a close eye on me. For the last 6 months, I've gotten more short of breath. And I've had a chest x-ray before, but I've never had a CAT scan. This is the first time they were actually doing a CAT scan. And when they did the CAT scan, they found there was disease there. And we know 44% of the time, we may not see stuff in our chest x-ray unless it's more severe, but we pick it up on our CAT scan, especially high-resolution CAT scan. But when I'm talking to the patient, I'll try to find an activity that brings on the shortness of breath. So I might ask her a question like this. Do you have a flight of steps at home? She might say, yes, I have a flight of steps at home. That's typically 13 steps. If I were to ask you every single day to go up that flight, would you get short of breath when you go up the flight of steps? She says, when I get to the top of the stairs, yes. You know what? I get tired. Then I'll stop there for a second and ask, do you get tired or do you get short of breath, right? Because sometimes we can be fatigued, and that can be perceived as shortness of breath. Sometimes they are short of breath, but sometimes they're not short of breath. They're breathless. So if you see them, they look absolutely okay. but they feel that they can't take a deep enough breath. So I'll ask her that one question. I'll ask her, when you walk up the flight of stairs, if I told you to do that activity every single day, would you have good days and bad days? If she tells me, something, that's interesting you asked me that, but I do have good days and bad days. So that's interesting. Do you have bad days and normal days, I'll ask her. If she says, yeah, I have actually normal days. Now that is interesting. If we had that interstitial lung disease, right, that is there every single day, Monday through Sunday, that means something else is changing. So it's so easy to chalk it up to what's going on there. So if you have day-to-day variability in your symptoms, I'm going to stress that one more time. If you have day-to-day variability in your symptom, think outside the box, right? And out of all those structures, the reason I took out these structures and spelled it out here is they behave differently. If you have day-to-day variability, it's going to be something to do with the airways. And if you live in Lancaster County or this area, think bronchial asthma. Because we see bronchial asthma without scleroderma, so forget with scleroderma, it's just an added-on complication which is easy to chalk it up to. And I don't want providers to chalk it up to that without being sure about it. Because then we will blame it to that, and our patients will continue to be short of breath, and this will gradually get worse. If you have day-to-day variability, one of the things that is out there would be, I would start thinking airways. It could be a simple thing like bronchial asthma, or someone who has been a smoker in the past, chronic bronchitis. The day he has more secretions, or she has more secretions in there, they become more short of breath. Or it could be a simple mucus sitting in the lungs. But it's got to be airway physiology. That is where your symptom is coming from. That is why it is so important to understand what is the driver of the symptoms, right? Because if that is the driver of the symptoms, I can make that person much better. So if she told me that, I know right off the bat, I'll tell her right there, something? You're going to feel better in 1 week. Now, many a times it's difficult. They'll say, I've had this for the last 6 months. And you're telling me I'm going to feel better now. Is that possible? Well, I'll say, let's take a look. And the sheer fact that they had a normal day, for me, it's a big thing. For example, you may have a patient who has got pulmonary hypertension, but they have good days and bad days. That means beyond the pulmonary hypertension, something else is happening. And like we said, sometimes it's not uncommon to have, we like to have a unifying diagnosis, but sometimes we have more than one. Especially when it comes to the lungs, we have more than one. Coming to the other thing is lung parenchyma. When the parenchyma is involved, the symptoms tend to be static or progressive. But you will not have this much of variability, right? But also remember, we could have interstitial lung disease, and we can also have bronchial asthma on top of that. So if a person, for example, got a new cat and now having postnasal drainage, right? So that person could be having bronchial asthma on top of that. So whenever you have day-to-day variability on top of whatever you may have, don't forget that is playing into it. And that is not an uncommon thing. That's why I wanted to stress on that. Then we have the blood vessel issues. Dr. Castle will be talking about pulmonary hypertension today. Pleuritis, surface of the lung can be involved. Typically, when the surface of the lung gets involved, the symptoms that you're going to have, it can be in the left or right. When it tends to be on the left side, we can sometimes, it can present, it could be a cardiac issue masquerading at that. But also if you find that it's annoying, it's here today, it's back here, it's back on this side, it might change with position, making us think that is musculoskeletal, but think pleuritis. And when in doubt, just give a short course of prednisone. They may feel better, the pain might go away. Or plaquenil is another thing we can give for serositis. The serosa are the lining that lines the heart, the lungs, and the abdomen. So sometimes when you have pain coming from those kinds of things, medications like plaquenil will help. Skin. If you have a lot of taut skin around the chest, that can cause it. And typically what happens with the skin disease, it tends to be more slow in terms of causing pulmonary symptoms than if it is a parenchymal. And we are going to talk a little bit more about risk stratification because I don't want to apply the rule to everybody. Muscles, this is interesting. So if that patient were to go up a flight of stairs and tell me, I get fatigued, I'm not so sure whether it's a shortness of breath or is it more fatigue. I'll ask them, do you feel like you've just ran a marathon? If she tells me that, it's probably more fatigue, more than shortness of breath. But if she tells me, for example, when I go to sleep at bed at night, I get more shorter breath, I start thinking about the diaphragms. Because we just talked about 40% of our breath that we take, our tidal volume as we would call it, comes from the diaphragms. So when we lay down flat, you can imagine what happens. That pushes up against the lungs, the diaphragm, and we get more shorter breath. So when they tell me that they're shorter breath when they lay down, It's important because not only when I get a PFT, I should be cognizant about that because I want to get a PFT with them lying down flat. I really want to unmask that. But that becomes important. I start thinking about those symptoms. So it only happens when they're going up a flight of stairs, when they lay down, I start thinking about the diaphragms. And sometimes what is interesting with these patients is when the muscle becomes weak, they also tend to retain carbon dioxide. And that makes them even more fatigued. It's one of those constitutional symptoms that sometimes we may see. They may feel a little foggy up here. And we know now, studies are now telling us that there is a higher incidence of obstructive sleep apnea. Pleural space, we talked about pneumothorax. Sometimes you can see a pneumothorax. That usually it's not a misdiagnosis. People will just get a chest X-ray and will be able to pick that up. So this is something I don't worry about. Pleural effusion, when I see it, I tend not to attribute it directly to the scleroderma of the lung, but to something else as a function of scleroderma or something else that is causing the pleural effusion. Okay, so I've seen this patient in the office. I've got a good history now. At this point, I know what the probable diagnoses are in the back of my mind. If she told me those things I just told you, I'll start putting her in different categories here. Next, I'm going to start entertaining the diagnosis of scleroderma because I really want to understand, where is this person going to be and what data I can use. So the strongest association that we have is with antitopoisomerase, the SCL70. We know that that is associated with the highest incidence of lung disease. But so once I have that marker, the next thing I'm going to do is I'm going to use some other data that's out there. On the published trials and everything, I'm going to look at those trials and say, let us try to see how those trials fit my patient. I'm not going to take my patient and fit it into the trials. It has to apply to my patient. So let us see what we know from the trials. We do know that most people with scleroderma have lung disease, and if I were to do a CAT scan, I would pick that up. I know the African race has more of scleroderma, tends to lung disease. I know that topoisomerase 1 is associated with a higher incidence of that. So in the back of my mind, I'm laying all these things down. I know that usually when I see the patient and I do a CAT scan or a PFT and I have significant lung disease, they are the ones who are going to progress. If I see someone who has had scleroderma and I did a CAT scan and it was normal, at 5 years, probably 85% of those patients will do well. I also know that not all the patient who has got lung disease progresses, only 15% progresses. So the way I tell my patients is 85% of the patients don't progress, right? And that's what we understood in the trial. So when we're trying to get patients to do trials, the problem is if the natural history, 85% of those patients are not going to get bad, then it's hard to see an effect of a new medication or not. It can throw us off, right? Then I do know there's some protective markers there, like centromere and RNA polymerase, that tend to be protective, right? So if I have these negative predictors here, there's no indication for immediate treatment because treatments are associated with side effects. But all our patients, we tend to follow them closely. So though we're trying to identify a phenotype, we say patients don't read textbooks, right? So to speak, medically speaking, so they do not have to exactly follow what we read, what we are taught in our textbooks. We have to keep our mind open and we have to individualize our patients. When we start being too focused on that, that's when we lose out our patients because not all of them are going to behave that way. We have to understand that. That is why it is so important. We see them in month 1, we see them in month 3. We tell them these are symptoms that you have to keep an eye on and we closely follow them. It's really a team effort of different specialists here because each one is trained to look at certain things. So how are you going to navigate? Once you have a diagnosis of scleroderma, how is your pulmonary provider going to take you through this process? The first thing they're going to do is get a good history, and we talked about that. Then what I would do is the next thing is I would get a few tests. Now, I don't have to go directly to a CAT scan. Sometimes I see people do a CAT scan because sometimes if I find that someone has a cancer there, then I might have to give them contrast, and I don't want to give contrast to my patients if I don't have to, right? Because I never know. I want to make sure we protect the kidneys as much as we can. So if I do a chest X-ray, say a mass, then I say, I have to give contrast. Otherwise, I'll just go with a high-resolution CAT scan. Oxygen saturation, we get an echocardiogram, and I'll get these blood work. So the first visit, I'll get those things, and I'll bring the person back. So when I bring the person back, what I'm going to do is how are we going to interpret the study? We don't want to be treating our studies. We want to see how our studies pertain to our patients, right? And why is that important? Let us see. PFTs, pulmonary function tests. I'm sure many of you have had a pulmonary function test. And how many times, how does pulmonary function test correlate with symptoms? Let's for a second think about how we do a pulmonary function test. You go into this chamber, you take a nice deep breath, they tell you to blow out hard, and they see how much of air you get down in 1 second and how much of air you get down in total, right? So it's something like this, right? And so if our FEV1 is low, that does not correlate with symptoms. We do know it only correlates with symptoms 30% of the time, right? If in some patients they are really short of breath and you do a PFT, it looks normal. I can't tell my patient your PFT look normal. You have nothing going on with your lungs. I still have to find out what's going on. And there are patients you see the PFT looks horrible, but they're able to run up a flight of stairs. That is because when we use an FEV1, the only time we breathe like that is probably when you blow out birthday candles, right? To blow out fast. It does not correlate with symptoms, right? So we have to be, every aspect of the PFT, we have to ask ourselves, what is it telling us? What is it telling the provider? And I have to correlate that with my patients. So I know scleroderma can cause, for example, a diffusion capacity of carbon dioxide. What that is we talked about the air getting through the lungs and getting to these alveolar sacs, and in the alveolar sac it's wrapped around with blood vessels. They'll give us carbon monoxide, the same carbon monoxide we always worry about, but it's in small doses. It gets into the alveoli, and it's very avid. The hemoglobin is very avid to that, much more than to oxygen, so it gets it across. And then we have the patient exhale after that, and the difference between what went in and what came out tells us how much got across. And that tells us how much of that tells us what is there that is preventing that from getting across. And that does not always have to be pulmonary fibrosis, right? It could be, let us say I have a patient who just came out of a acute respiratory tract infection. This has been a season when we had a lot of viruses out there. If I did a PFT, then it would look horrible, right? So I have to ask myself, how does it correlate? Does this person have, was this person a smoker? Does this person have asthma? Does this person have anything that is sitting in the alveoli that is preventing my DLCO to look, is making it look worse than what it is, right? So when you have this very noisy DLCO up and down, but it's overall, the aggregate is the same, it's not interstitial lung disease. You have to see persistent worsening of the DLCO. That's when you can say it's consistent with that. Sometimes for example, if you have a patient in pulmonary edema, the same thing would happen. Our DLCO might go down. Initially it'll go up and then it'll go straight down. If the diaphragms are having an issue, our DLCO can be an issue. When you have mucus sitting in the lung, our DLCO can be an issue. So when you're looking at these tests, and you can see it's so important for us to look at the test and once again not treat the test but to treat the patient. So that's the first test I will get, and I'll use that in the context of my patient. And I just spoke about the patient who has muscle weakness. If they have muscle weakness, but you're upright and you do a pulmonary function test, it's going to look better because the diaphragms are being helped by gravity. But you take the person, have the person do that in a laying down pattern, and if that really drops down, that is suggestive of diaphragmatic weakness, and probably maybe a lot of the shortness of breath is coming from that. Okay. So this is a set of as a gross specimen of a normal set of lungs, okay? This should be nice, and you can see it is smooth on the surface. There are no cavities in there. So if I were to take a picture of this, that's what we do with a chest x-ray. If this was sitting in someone's chest and I take a chest x-ray, this is how a chest x-ray is going to look. What we're going to see here is we're going to see the heart in the middle, the diaphragms, these two things are the diaphragms, and then the lung should be black. Black is always good in a chest x-ray or a CAT scan. White is not good. It's okay to have white here because we have the heart here, but if you look up and down here, everything's black, and that is good. And what is interesting is, if you look at the side profile here, the largest part of our lungs is in the bottom. So, and that is a part of the lungs that actually helps us breathe the most. So if we have anything going on in the basis of the lungs, we become more symptomatic. That is why you'll find in patients who have got COPD, where it eats up the top of the lungs, that they only become symptomatic later on in life. If smoke didn't have the thing of rising up and causing damage on top, many of our smokers would have been much symptomatic at a younger age. But since scleroderma tends to have a propensity on the basis of the lungs, that's why we can become very symptomatic and hypoxic. But this is how a normal chest x-ray would look like. Going to the next slide here, this is how a CAT scan would look like. Once again, black is good, white is not good. And you can see, you're seeing these black dots and lines here. They are blood vessels coursing through the lungs, but they look normal. In persons who have got GI reflux issues, you'll find they're very patulous esophagus here. You can see it's nice and small now, but sometimes you can find it big. And then we have, that's your CAT scan there. You're looking at the CAT, you're looking at yourself in that. We're looking at ourselves in that one. You can see it's nice and black, okay? So that is good. But what happens when we have, and this is a high resolution CAT scan, I'm going to skip this slide here. But what happens when we have like scarring of the lungs. Now, this is not a scleroderma patient. This is just a pathology. I just want to show you when your provider talks about honeycombing, what are they referring to? This is a cut specimen of that. And typically in scleroderma, we tend to have our disease in the bottom part of the lungs. And what you're seeing here, that holes is what they're referring to as honeycombing. And as you go to the periphery, the holes may not be that distinct, and that's when we call it as reticular lines we see there. But this is in the bottom part of the lungs, and that is the biggest part of the lungs. That's why when the bottom part of the lungs gets affected, we can become symptomatic. Or even if your diaphragms are weak, it affects the bottom part of your lungs. The bottom part of your lungs cannot expand, we tend to be symptomatic. Now, if I were to take a chest x-ray of this, let's see how it would look like. If I were to take a chest x-ray of this, once again, the x-ray on this side is normal, it's nice and black, right? But on this side, as you're coming down, you have more air there, so it should have been darker, but you can see all these lines here, crisscross lines. So that is how it will look on a chest x-ray when you have scarring. Now this is, I would call it moderate disease, but earlier on we may not pick it up on a CAT scan unless we really very carefully look at those. May not see it on a chest x-ray unless we carefully look for it. But that's how, if you take a picture of that, that's what you're going to see, okay? And now I'm going to show you a CAT scan of that. And you can see that on the left side you have a normal set of CAT scan. Everything is nice and black here. The blood vessel looks okay. But on the other ones there, the other one there, you can see all those crisscross lines. Now that is what we refer to as scarring of the lung. And if this person has scleroderma and no other disease, we can chalk it up to scleroderma. There is no radiological sign that is pathognomic for scleroderma. Okay. So it's our X-ray findings along with our clinical symptoms and our blood tests and everything that we put together and say this diagnosis is of scleroderma. The reason I say it's not, the reason I'm pointing that out is sometimes when we have aspiration because of GI symptoms and we see some scarring, we might mistakenly connect that to our scleroderma. But there are some parts of the lungs that we are going to see those scarring. Typically, if someone is aspirating when they're eating food. So we can aspirate either when the food goes down or we can aspirate when we reflex it back out, right? More often it is the latter, when we reflex it back out. So when you reflex it back out, what is the position we normally are? We are laying down flat. It happens usually at night or when we assume a supine position. So it tends to be more in the dependent portion. So if you start seeing a pattern like that, then I would say, you know what, maybe the person has scleroderma, but what is driving those changes in the lungs now is aspiration. Maybe we need to focus on the aspiration, or maybe we need to treat that. And when we have aspiration, it's not just the lung that gets scarred, the airways get swollen. So those patients are going to behave like our asthma patient. Because those airways are very thick, that is the only time probably when we don't have significant day-to-day variability. But we should keep that aspiration bronchitis physiology in the back of our mind because that could be an issue. However, so what test am I going to order if it's a reflex? I'm going to order a reflux study. If I ordered a swallow study, it's going to look normal because nothing is happening when the person is swallowing, it's reflexing up. So I should look at the pattern. So pattern recognition in radiology is very important. Second thing, if that person were to swallow when that person eats, it's typically going to go the right side of our lungs, the middle part of our lungs. Then I'm going to chalk it up to that, and the test I'm going to get is a swallow study. The other thing to remember is, when we take medications like our PPIs, like in protonics or medications like that, we still have the reflex. It's just that the reflex is not that acidic to cause damage. The other thing to remember, if you go back to embryology, how we develop as a fetus, the stomach, the esophagus, and the lungs, they develop from a structure called the foregut. Okay? And sometimes what happens when the lower part of the esophagus gets tickled because of reflux, it can cause our lungs to go into spasm, bronchospasm. And they're typically, I would favor giving them ipratropium or albuterol because they tend to respond to that better sometimes. And that is important because what happens is sometimes we can have that reflex and we may not have symptoms, right? That's the idea of having the Bravo capsule put in because some patients may not talk about, I'm having it up here coming up to the back of my throat. I don't feel it's getting into my lungs. All it is doing is tickling the lower 1/3 of the esophagus. That's why when you put that capsule down and the capsule is able to pick up the acidity, it is telling us we have reflux because these patients are asymptomatic. They don't reflex all the way up, but they reflex the lower part of the esophagus and that can cause bronchospasm. Again, symptom of shortness of breath. We find the scarring in the lungs. It's easy to chalk it up to that. Maybe the scarring is there, but if the airway was causing most of the symptom, go after the airway. Treat the airway. Maybe the airway leading to that scarred part of the lungs is the one causing the trouble. So sometimes we have to go and look at that. Okay, so now we took a good history, we got the basic tests, we have interpreted those studies, and now that's when we move on to the next step. That's when, I might send a patient to Dr. Castle and say, I cannot really account for all the symptoms here. I think we really need to have a right heart catheterization here. Rarely ever do we need to do a biopsy, very rarely. And the other thing to think about in these patients, sometimes I also get a sleep apnea. I just evaluate them. If the carbon dioxide is high, I start thinking about also symptoms like sleep apnea. One of the things that may be a little challenging in our patients who have a whole lot of reflexes, when you put them on a CPAP machine, they tend to swallow a lot of air, and sometimes that can cause more reflux. So something that we have to be careful about. And if we have reflux, sometimes I see patients using 1 or 2 pillows. That is not good. They tend to slide down, our necks tend to get kinked. The best thing to do is to use a hospital bed or just keep 2 or 3 inches of blocks of wood at the head end of the bed so the whole thing is tilted this way, rather than using more pillows. So by the time we have gotten to this step, now we are ready to formulate a diagnosis. And it may be more than one diagnosis. So for that patient we talked about, has a diagnosis of scleroderma, but in the last 6 months the shortness of breath has been getting worse. She has good days and bad days, and there's a big difference between a good day and a bad day. We might say, you have these interstitial changes, but I'm not so sure it's driving your symptoms. Have you ever had a CAT scan done before? She said, I had a CAT scan of my chest done 15 years ago. And when you pull up that CAT scan, you see the same amount of interstitial changes was then and now. She was an artist. She was probably using a spray paint, that was getting into the lungs. So here now we're able to understand that she has had that. She always had that. It is not driving her symptoms now. Maybe when you treat them, there you go. It's going to make a huge difference. And we did not have to add medications that had a lot of side effects. And you can continue to monitor the symptoms. Now the thing with scleroderma is treat what is treatable. That's the first thing I always stress, that is to treat what is treatable, and also identify what is driving that person's shortness of breath or pulmonary symptom. It may not always be scleroderma. It gets chalked up to that sometimes, but it may not be that. So it's one of those things when you start understanding this symptom, to bring it up to a provider and say, no, if I do have interstitial lung disease, why am I having so much changes on a daily basis? Or if I'm having pulmonary hypertension, why am I having those changes on a daily basis? I'm having this non-specific, I'm having these acid reflux, and I'm having these changes in my lung. Do you think it's coming from that, not from my scleroderma? So these are things. So it's very important. That's why I wanted to focus today on this thing, the pulmonary symptoms. I just wanted to focus on that because I know the return on investment as a patient is going to be high on this. All right. Any questions?
I have a question. So say that you were saying medications. What medications do you prescribe for, somebody that would have fibrosis or
Of the lungs?
right?
We have 2 studies. We have the.
Could you repeat the question so
Sure.
we'll be able to hear it on the video?
Sure. The question is, if someone has fibrosis, what medication should we be prescribing our patients? The first thing to remember is only 15% of our patients are going to progress. The second thing to ask ourselves is, those interstitial changes that I'm seeing, is it driven by scleroderma? Right? Because if it's driven by something else, like continuous aspiration, we need to fix that. If you really think it is driven by scleroderma, and we are seeing this patient for the first time, we know that they get worse initially upon diagnosis, right? We know also when you see changes on the lungs that are new, that's the time they're going to progress. So we have a couple of studies that we can go by. The first study was the Scleroderma lung study 1 that came up. It compared Cytoxan, right? And they found that when you started this patient on Cytoxan, they got better, but afterwards they came back to baseline, right? So people have postulated maybe we didn't give it long enough. Then they had the Seattle Lung 2 study come up. That compared cyclophosphamide with mycophenolate. Mycophenolate was for 2 years, cyclophosphamide was for 1 year. They found that they got better, but after 2 years of mycophenolate was just as good as 1 year of that. So lung function had improved, but then it came down to baseline. They were small studies. It's very hard to analyze these studies because the natural history of patients with scleroderma is 85% of those patients would not have progressed anyway. So to say that this is not efficacious, I'm not sure. This is the first time we found something that is exciting in scleroderma. I think what we need to look at is to take it with a pinch of salt and say, what else did it show us? Well, it showed us a couple of things. The patient felt better. The breath, they were breathing better. The cutaneous changes were better. So a lot of centers you will see If they can attribute it to it, and it is progressive disease, and it meets all those criteria, they will start them on probably mycophenolate. And then we have got a couple of other things out there. It's not ready for the real world. We still have to look at it. You know, you might read about stem cells, you might read about Rituxan and all those things. We still have more data we have to see. But sometimes you'll find, especially when you go to big centers, they will sit down and say, this has not worked. Why don't we give it a try? Let us see what happens. They might give it a try. And you know, that is not bad thinking either. That is, I think what they're trying to do is they're trying to individualize that patient and see what is going on with this patient. But I think what we always have to do is step back and reevaluate the situation. Because sometimes a lot of things falls in between that. And we get so targeted and so tunneled on the scleroderma that we forget what else. Because with the lungs, a lot of other things are there. And we have to be careful. If there's someone in the Lancaster area, you know, when I see with patients with these symptoms who have shortness of breath that comes and goes and a post-nasal drainage, very often is the asthma. Even our COPD patient, when they get admitted all the time, it does not mean the COPD is getting worse. There's something called an asthma-COPD overlap. It's the asthma that is driving those symptoms here. So we have to be also cognizant of where the residence of that patient is, you know. And so it's important. I think it's most important that the patients bring this to their providers. I think that's really key, yeah. And ask those questions, why? And we should always be able to try to understand why the symptoms are behaving that way. When we do that, we are going after the pathophysiology. We are putting out the fire and not the smoke. And that's what we should be doing, not putting a Band-Aid on it. Yes?
I have a question. I've been on Nexium for as long as I can remember, and the doses has gotten basically higher. And then they also added Pepsid at night.
Right.
Now, all this, I still get acid reflux. Not maybe as often, but it comes up from my stomach and it stops here, and it's just a burning, horrible, tasting thing. So right now, I think my next step is the actual tiredness and the pulmonary piece of it, that I'm going to be doing GI testing now. So I have another step to go just to get to that point.
That's right. So you'll have this GI tech. So what you probably have is the dilated. The question is, we are having symptoms of reflux. We have probably been maximized on the medications. We have a proton pump inhibitor and we have an H2 blocker. Despite that, we are having symptoms, right? It's still coming up. What happens here? Will an endoscopy help me? Is an endoscopy going to fix the problem? Probably the endoscopy is going to reinforce what we know, but that is coming up. The question is, how do we take care of that? You know, it is a challenge. No doubt about that, it is a challenge. A few things we can do is, I think the head end of the bed is a good thing to do. Keep the head end of the bed elevated. Okay.
Just the mattress part? Or
the whole bed, and that's important. That whole bed thing is really important. Use 3 inches of blocks of wood to keep it up. Don't use 2 or 3 pillows, because what ends up happening is we just king the neck. Yes, and we slide down, right? And then we have those triangular things that we can slide behind. That also doesn't work, unfortunately. Yeah, it's to really, you know, you can ask for a hospital bed. That's a nice way of doing it. Yeah. Or if it becomes difficult, yeah, you know. I know. Oh yeah. Worst case scenario, use 3 inches of blocks of wood. And if you sleep on a recliner and you notice your symptoms are better, it tells you what you need to do. Okay, right there. Yeah.
You get plastic things from Bed Bath & Beyond. They go under the feet of the bed.
Yeah, the legs of the bed, right?
Next trip. That's great, okay. You got your tools ready?
Yeah, they're in my truck.
Okay.
Dan?
Assuming that your cough is from the reflux, aside from those meds that she was talking about, is there any other med that can help control the cough, or is that it? You just try to control the reflux so that controls the cough?
No. Yeah, so we do know a couple of things. So the question is, assuming it is from the reflux and we are already on those medications and we still have the cough, right? The first thing to do is to ask ourselves, is the cough coming because of the reflux, right? And if you find that it is coming from the reflux, one of the things that probably I would ask myself is, if we cannot control what is getting into the lungs, what can we do to the lungs to help tame it to what's getting into it? I probably will think about an inhaled steroid. And it's interesting that you mentioned that because you also told me that you respond well to prednisone. So what exactly gets better with the prednisone in your case?
Joint pain.
Okay.
Let me follow up with another
Right.
personal question.
Right.
As soon as I lay down, immediately I start coughing. It's in my lungs. I can feel, I'm assuming the mucus is changing in my lungs and I'm trying to cough it out. Is there anything I can do to alleviate that?
Do you have any postnasal drainage with that?
Yeah.
Okay. So first what I'll do is I'll ask myself, is it coming from your acid reflux? Or did the acid reflux trigger a reflux bronchitis in your airways being inflamed? I would give you a trial. So if that is the hypothesis now, we treat the hypothesis. I would give you an inhaled steroid with a bronchodilator, Advair, Symbicort. Make sure the technique was demonstrated to you. Give you something for postnasal drainage. Call you back in 6 weeks, and you tell us, see how you feel. If those symptoms got better and you still have the reflux, we could not stop the reflux, but we control the lungs respond to the reflux. So if we cannot fix the problem, what we try to do is we try to tame down the lungs, calm the lungs down. That's what I do. Because if you remember one thing, the lung is the only organ in the human body which is exposed, right? So the way it takes care of itself is when things get into it, it produces mucus, which is a good thing. Because the mucus will trap whatever is there, and you're coughing it up. So you're responding to that. And sometimes you'll find the chest congestion. Sometimes you feel, I want to take a deep breath. I can't take a deep breath, If you have any of those symptoms, I would treat that airway inflammation. I would give you, I would treat you with a postnasal drainage because we cannot really treat asthma without treating what else is getting into the lungs. It may not be just the reflux, it could be a postnasal drainage also, in addition to that. And then see how you feel. And in 6 weeks, if you find a pattern of getting better, I would probably stay on it. If it didn't make any difference, chalk it up to reflux.